Okay, good morning, everyone. My name is Kenny Wu, and I'm a program coordinator here at Walker CTSC. Thank you, everyone, for joining us today in our third presentation, I believe, in a series of 4. Today, we're joined by John Altman and Ruben Diaz from the Hospital of Special Surgery. This presentation will be done in English and Spanish. If you want to ask any questions or you want to talk to the presenters, there's a chat function at the bottom. You can type in your questions, and the presenters will answer it during the Q&A section of the presentation. At the end, we will have a short poll about today's presentation, and please fill it out if possible. And I'll do it in Spanish. Muy buenos días, mi nombre es Kenny Wu y yo soy el coordinador de programas en Walker CTSC. Muchas gracias a todos ustedes por atender nuestra presentación el día de hoy. El día de hoy vamos a tener una presentación sobre la diabetes. La presentación va a ser en inglés y español. Si tienen preguntas en la parte de abajo, hay una sección, chat, para hacer preguntas. Los presentadores del día de hoy son John Altman y Rubén Díaz del Hospital for Special Surgery, y vamos a tener una encuesta sobre la presentación al final. Por favor, llénenla si pueden. Esta presentación va a ser grabada. Si quieren verla de nuevo, ustedes pueden accesar a nuestra página de YouTube y se llama Walker CTSC. John?
Hi, good morning. My name is Joan Altman. I've been a registered nurse for over 35 years, and most of those years I've spent in community education. Currently, I'm the coordinator of the Nursing Community Education Program at Hospital for Special Surgery, and here's my ID. Mi nombre es Joan Altman. He sido enfermera registrada por más que 35 años, y la mayoría de estos años lo he pasado en educación comunitaria. Actualmente soy el coordinador del programa de la educación comunitaria en el Hospital de Cirugía Especial. Hoy, I have the pleasure of working in the same office as Ruben Diaz, and I see firsthand his knowledge, dedication, and love for the work he does. First, as a nurse practitioner, and he's developed this entire presentation today, and then as a certified diabetes educator. He's also faculty at NYU, in nursing, and he keeps up with the most current knowledge about diabetes and much more. Tengo el placer de trabajar en la misma oficina que Ruben Díaz y veo de primera mano su conocimiento, dedicación y amor por el trabajo que hace, primero como enfermera practicante y luego como educador certificado en diabetes. También es profesor de la Universidad de Nueva York en enfermería, y se mantiene al día con sus conocimientos más actuales sobre la diabetes. Hospital for Special Surgery is a specialty hospital for orthopedics and rheumatology. We're considered #1 for orthopedics and #3 for rheumatology in the nation. We're a magnet program for nursing excellence, and our mission is to provide the highest quality care, improve mobility, and enhance the quality of life for all. Ruben.
Hospital especializado en ortopedia y reumatología. Es #1 en ortopedia y #3 en reumatología en la nación. El programa es de reconocimiento de Magnet para la excelencia de enfermería, y nuestra misión es proporcionar atención de la más alta calidad, mejorar la movilidad y mejorar la calidad de vida para todos.
As Kenny said earlier, there's going to be a survey at the end, and we'll ask you if you could please fill it out so we know how we did and if we need to change anything and do better in the future.
Gracias por hacer la exposición de hoy. Al final de la clase va a haber una breve encuesta. Si por favor la pueden completar para ayudarnos a ver cómo hicimos y saber un poco sobre ustedes. La encuesta es anónima y ayuda a mejorar nuestras sesiones, por lo que si puede llenarlo, estaremos muy agradecidos.
So today is an overview. What we're going to do, talking about diabetes, is to summarize the treatments and goals. Today we're talking about medicines and treatments for diabetes, whether it's type 1, type 2, or gestational, which is when a woman is pregnant. We're going to talk about A1C, hemoglobin A1C, and self-monitoring of blood sugar, goals to step up, step down, or stop medications. We're going to talk about insulin, the most unpopular and the least side effects, needle phobia, non-insulin injection options, and oral medications.
El día de hoy vamos a repasar diabetes tipo 1, tipo 2, diabetes gestacional durante embarazo, diabetes durante embarazo. También el A1C y el azúcar en la sangre de propio cuidado, de autocontrol. Los objetivos del A1C ayudan para hacer decisiones en aumentar, disminuir o suspender medicamentos si es posible. Vamos a hablar sobre insulina, la menos popular, con menos efectos secundarios. La fobia a las inyecciones y opción de inyección que no tenga insulina, medicina para diabetes y medicamentos orales. Diabetes tipo 1 quería enfocar en el tratamiento. Como pueden ver en todo tipo de diabetes, la fundación es cambios nutritivos y ejercicio. Luego, en tipo 1, la insulina se requiere para controlar el azúcar y la terapia con insulina debe imitar lo que el páncreas, si está funcionando completamente como entendido, tratamos de imitarlo con insulinas externas, insulina basal o lenta y reactiva que es dado como bolo antes de la comida. Importante evitar los episodios de azúcar alta y azúcar baja, que es hiper y hipoglucemia. En tipo 2, puede ser que sea suficiente el ejercicio o cambios nutritivos, pero a veces no es suficiente y es necesario incluir medicinas orales, inyección sin insulina que se llama GLP, que son medicinas nuevas, y puede que sea que requiera insulina. En diabetes gestacional, otra vez, ejercicio, comer apropiadamente para manejar el azúcar, puede requerir insulina y hay orales que usan en ocasiones, pero no es preferido. La insulina es preferido para diabetes gestacional. Tipo 1, la meta es mantener control de la glucosa en la sangre y prevenir ketoacidosis diabética y complicaciones a largo plazo. Tipo 2, otra vez, metas similares y también gestacional. Incluso en diabetes gestacional queremos prevenir complicaciones del embarazo, que incluyen presión alta, preeclampsia, que se manifiesta como daños a órganos como los riñones, y también evitar tener un bebé grande o prematuro que puede resultar cesárea más temprana y distocia de los hombros.
So to talk a little bit about type 1, type 2, and gestational diabetes. For type 1 diabetes, the kinds of treatments that are included are lifestyle changes, and type 1 diabetes, a person will need to take insulin, will be dependent on insulin. So insulin therapy mimics slow and reactive secretion of insulin in response to glucose levels. So glucose levels are going up and down in our blood. And to avoid hyperglycemia, which is high sugar, or hypoglycemia, which is low sugar. For type 2 diabetes, which over 90% of people with diabetes have type 2 diabetes, there's lifestyle changes, which include exercise and diet, which we talked about last time. But sometimes that's not enough to bring down glucose levels, and so medications can be added. Oral medications, pills, and sometimes requiring insulin. For gestational diabetes, that's when a woman is pregnant and has diabetes during her pregnancy, their lifestyle changes can help, and insulin is also sometimes given. Oral medications are also sometimes given, but it's mostly insulin. The goals for all three is to keep the blood glucose, which is the same as blood sugar, keep the blood glucose levels at a good level, not too high and not too low. In gestational diabetes, when a woman gets diabetes during pregnancy, then there are risks to the baby. The baby may be very large, or there may be other problems during the pregnancy. So it's really important to treat all three of these types of diabetes.
La meta es glucosa en la sangre. Para las personas que están registrándose la glucosa en la casa, En ayuno antes de comer, los niveles deben de ser entre 80 y 130. Después de comer, 1 o 2 horas después de haber empezado a comer, si se la registra, debe estar en menos de 150. Cualquier otro tiempo, menos de 180 es preferido. Evitar el azúcar baja es clave. Las metas de A1C varían dependiendo de la persona. Menos de 7% es por lo general, y eso se traslada en una glucosa en la sangre de un promedio de 150 a diario. Las metas ajustadas que se pueden tener a niveles más bajos, de 6.5% el A1C, es reservado para personas más jóvenes, más saludables, menos y evitar la hipoglucemia. Si se puede alcanzar estas metas en personas que caen fuera de este grupo, se prefiere que se haga sin aumentar la hipoglucemia. Metas más flojas, que son metas más altas, de 7,5 a 8, se reserva para personas mayores con menos esperanza de vida, que tienen vida corta, que no se espera que vivan, por ejemplo, más de 10 años. Tienen algunas enfermedades del corazón y del sistema sanguíneo, en cual disminuir el A1C a metas más bajas pueden causar daño, y también es probable que tenga niveles bajos de azúcar si tratas de bajar el A1C demasiado. Si no puedes reducir el A1C al menos medio porcentaje, es 0.5%, en 4 a 12 meses se considera una respuesta deficiente al tratamiento, y deben de hablar con su proveedor de salud para ver lo que pueden hacer. Otra vez, los cambios dietéticos y ejercicio, y también repasar las medicinas o medicamentos que está tomando presentemente.
So what are the blood glucose targets for adults? The blood glucose goals, so when we talk about fasting blood glucose, sometimes a doctor or a nurse practitioner may say that to you. That means before eating or having a particular period of time that you haven't eaten. So that we want that to be between 80 and 130. And that is the sugar that you see when you stick your finger and check it in your glucometer at home. After eating, about 2 hours after eating, less than 150, and any other times less than 180. Avoiding hypoglycemia is key, so low blood sugar. We don't want to have high blood sugar, but we also don't want to have low blood sugar. A1C is when the doctor or in the providers, in the health provider's office, they take out blood to see what is your blood sugar level over a period of a few months, and that's the hemoglobin A1C. So a hemoglobin A1C of less than 7% is what we're looking for. And what that connects to, what that is equal to, is about 150 would be your blood glucose level generally when you check your blood sugar at home. There are tighter targets for younger, healthier adults, and that would be between 6 and 6.5% would be a great hemoglobin A1C. There are looser targets for older adults who may have a shorter life expectancy or may have other comorbidities, meaning other diagnoses which could interfere with this. And that would be 7.5 to 8. If a person is not lowering their A1C at least 0.5% in 4 to 12 months, then we know that the treatment is not working the way we want it to, and we will come up with you with a better treatment.
Establecimiento de objetivos terapéuticos para adaptar los ejercicios, comidas y medicamentos si es necesario. Metas de glucosa cuando está registrándolo usted propiamente en la casa. ¿Dónde queremos que estén nuestros niveles de azúcar en la sangre? Nosotros repasamos eso anteriormente. Las metas de A1C, minimizando el riesgo de hipoglucemia, minimizando el aumento de peso, el régimen más simple que se adapta a su estilo de vida, teniendo en cuenta la esperanza de vida, otros desafíos de salud, la motivación y el apoyo disponible. Nosotros vemos todas estas cosas para tener un régimen que funciona para usted, individualizado. Debe de preguntarse si sus objetivos coinciden con los de su proveedor de atención médica y saber por qué estos objetivos son importantes y saber cómo lograr tus objetivos.
So, how do we establish therapeutic goals and tailor those goals with you? Well, first of all, what do we want? What do you want as the patient? What do we want as the providers? The blood sugar to be. What are the A1C targets? We just talked about hemoglobin A1C and what are the targets, but this is in conversation between the provider and the person living with diabetes. One thing is very important is minimizing hypoglycemia, because actually a person can pass out when their blood sugar is too low. Minimizing weight gain. We know that there's a connection with weight and fat and diabetes and higher blood sugar. And putting together the simplest regimen that fits your lifestyle, keeping in mind expected life expectancy, other health challenges. How motivated are you? How motivated is the person with diabetes, and how can we help them to be more motivated? And also, what kind of support does the person have? That's really important. And one thing to think about as the patient, or maybe you're the advocate for the patient, it's a friend, it's a family member that you're supporting, do the goals of the healthcare provider match the goals of the patient? Because if they don't, this is a time to talk to the health provider about it. And why are these goals important? Why are these goals important? Why does your health provider say, this is really important? Do you understand why? And does the person with diabetes understand why if that's not you? And do you know how to achieve those goals? How do you get there?
¿Por qué es tan importante mantener la glucosa, el azúcar en la sangre a un nivel saludable? La primera razón, la glucemia alta daña los vasos sanguíneos, tanto grandes como pequeños. Primeramente los grandes, las enfermedades cardiovasculares, enfermedades del corazón y del sistema circulatorio son la causa número 1 de muerte en personas con diabetes. Los adultos con diabetes tienen más del doble de la posibilidad de morir de enfermedad cardíaca o accidente cerebrovascular que las personas sin diabetes.
So why is keeping blood glucose at a healthy level so important? A major reason that a lot of people don't know is that high blood glucose damages all of the blood vessels, both large and small. So first we're going to talk about the large. Cardiovascular disease, which means diseases of the heart and the entire circulatory system, are the #1 cause of death in people with diabetes. And adults with diabetes are more than twice as likely to die from heart disease or stroke than people without diabetes. But if blood sugar is kept under control, then these risks diminish a lot.
¿Y por qué es tan importante mantener la glucosa en la sangre, el azúcar en un nivel saludable? En segundo lugar, son los pequeños vasos sanguíneos. Los riñones y los ojos tienen muchos vasos sanguíneos pequeños. Por eso algunas personas con diabetes pierden la vista o se disminuye o progresan a insuficiencia renal y a veces necesita diálisis. Es lo que estaba diciendo John anteriormente, que por eso queremos mantener los niveles saludables, porque sabemos que a largo plazo mantener esos niveles saludables pueden prevenir estos incidentes.
So why is keeping blood glucose at a healthy level so important? Well, we just talked about the large blood vessels. Now we're going to talk about the small. If you look at the picture on the right of the three people, the one on the right is when somebody has diabetic retinopathy. Diabetic retinopathy is the leading cause of blindness in this country. And it comes from diabetes because the small blood vessels in the eyes are affected by high sugar levels. Kidneys also. We've all talked to people who are on dialysis or are in some level of, have kidney problems and may have a diagnosis of early or late kidney failure. And that is also because of the small blood vessels in the kidneys that are affected by high levels of sugar. So keeping blood glucose under control has an impact on every part of our bodies.
Otra vez, terceramente, y el último que vamos a repasar en relación a los niveles saludables de azúcar, daños a los nervios, la neuropatía periférica en las manos, en los pies, es un término utilizado para describir el daño a esos nervios y ocurre en 1/3 a mitad de las personas con diabetes. Causa dolor y ardor en las piernas, hormigueos en los pies, en las manos, la falta de sensibilidad en los pies que pueden provocar heridas que no sanan y en peor casos provocar amputaciones. A personas que mantienen los niveles saludables pueden prevenir o disminuir los problemas existentes que si tienen ya daño periférico de neuropatía, puede disminuir o mantenerlo al nivel donde está en esos momentos.
So the last reason we're going to talk about is nerve damage, why it's so important to keep blood glucose, blood sugar low. So peripheral neuropathy, that's a term to describe damage to the nerves in the feet and the legs, occurs in 1/3 to 1/2 of people with diabetes. Sometimes people talk about pain and tingling in their feet and in their legs, and it can be very painful. Also, it can cause numbness. So this lack of feeling in the feet can lead to wounds that we don't see. And one thing to talk to your provider about is foot care. We're not covering that today, but it's something very important to pay attention to, because ultimately what can happen and what does happen to some people with diabetes is that they end up having amputations because they have ulcers like that are shown in this picture, and they get worse and worse and they can't be cured. So another reason to keep our blood sugar as low as possible.
Okay. Los medicamentos pueden ayudar. El A1C normalmente cada 3 meses, máximo cada 6 meses, se deben de registrar con su proveedor de salud para ver cómo le va el tratamiento, y si es solo comida y ejercicio, igualmente a ver cómo le va. Y estos niveles pueden ayudar a decidir si pueden rebajar medicinas, quitar medicinas, o si llega a un nivel de salud que puede quitar las medicinas, o usted propiamente discontinúa una medicina. Podemos ver si mantienes los niveles de A1C a niveles aceptables. En tipo 1, recuerda que siempre va a depender de insulina, pero la cantidad puede cambiar. El A1C de 5.7 en adelante se puede utilizar medicinas, aunque muchas personas prefieren depender de cambio de dieta y ejercicio, pero sí hay estudios que empezar, por ejemplo, metformina en etapa de prediabetes puede prevenir desarrollar diabetes tipo 2 a largo plazo. En menos de 100.5, si tiene ese A1C, por lo menos comenzar metformina es importante, si no es contraindicado para usted. Y cambios de estilo de vida, que eso significa la dieta y el ejercicio. El A1C mayor de o equivalente a 7.5%, a menudo se recetan 2 medicamentos y otra vez la comida y ejercicio. Más de 9% con síntomas, generalmente se receta la insulina y la misma fundación de dieta y ejercicio. A1C mayor de 9%, llegando a 10, 11, 12, con síntomas. Generalmente se recetan 2 o 3 medicamentos, pero puede ser insulina no más. Una combinación es que se hace, y otra vez cambios en el estilo de vida.
So medications can help. Medications and hemoglobin A1C. If your A1C is between 5.7, is above 5.7%, but under 7.5, usually the start is with metformin, which is a pill, and maybe another single medication, and also lifestyle changes, diet changes, exercise changes, moving more. If the A1C is greater than 7.5, usually 2 medications are prescribed. But lifestyle changes, you'll see on all 4 of these bullets, lifestyle changes are included. Even just a little bit of exercise that we talked about and during the last class can really make a difference. If the A1C is greater than 9 and there are symptoms, usually insulin is prescribed plus lifestyle changes. And if the A1C is greater than 9 with symptoms, then usually 2 or 3 medications are prescribed with lifestyle changes. The goal is always to bring that sugar down so the issues we talked about a minute ago, heart, amputations, kidneys, vision, are avoided.
And just to reinforce on what Joan was saying, this is something that I utilize to decide whether to step up, step down your regimen or discontinue a medication, or if you decide to self-discontinue a medication, looking at this A1C every 3 months, maximum every 6 months, not waiting longer than 6 months would be how to tell whether or not what you're doing is working. So it's very important to follow up with your healthcare provider.
Thanks, Ruben.
Yeah. And again, in type 1 diabetes, the person will always require insulin, but the dosing can significantly change.
So why are there so many different types of medications for diabetes? Sometimes your provider will prescribe a few, as we just said. Why doesn't one medication do the job? And on the next slide, Ruben is really going to explain how each medication affects different parts of our bodies and how they do different things with the goal of bringing the blood sugar down.
¿Por qué hay tantos tipos de medicamentos para la diabetes? Algunas veces su proveedor les recetará algunos medicamentos distintos y vamos a sobrepasar próximamente cómo diferentes medicamentos funcionan. The site of action of glucose lowering agents. So I'm not going to go over each individual medication, but I did want to provide a visual of how these medications work at different points in the body. And going back to a question I had at the very start of this program, for example, epicardial fat, if I want to affect fat tissue, I'm looking at adipose tissue, I'm looking at TZDs, medications. We can see where insulin works so that the glucose can be stored in muscle cells, for example. And we know there are medications that work in the brain and the metabolism to lower glucose. And in the kidney with the newer medications, which we'll review at the very end, to help decrease the absorption of sugar in the kidneys. And metformin, which is first line, if it's not contraindicated, works primarily in the liver to decrease excess glucose production and excess lipid storage. So hay razones que recetamos medicamentos distintos. Si pueden ver en esta pantalla, no voy a repasar cada medicamento individual, pero pueden ver, por ejemplo, insulina ayuda el azúcar a entrar en las células musculares, en la grasa, en el tejido, podemos ver, hay un medicamento que se llama TZD y eso ayuda a aumentar el estoraje, el almacenaje de la grasa. Si alguien tiene problemas cardiovasculares en el corazón, se ve a través de ecocardiograma, ultrasonido, grasa en el corazón, se puede usar esta medicina para ayudar. En los riñones, las nuevas medicinas que vamos a ver al final y repasar, hay medicinas que ayudan que los riñones no absorban toda la glucosa que normalmente absorbe para orinarlo. Y metformina, que es primera línea, es un medicamento si no es contraindicado, que disminuye la glucosa, la producción de glucosa en el hígado. Y también hay medicinas que funcionan en el cerebro para ayudar en el metabolismo para disminuir la azúcar. So, vamos a hablar de la insulina primordialmente, porque algunas veces las personas piensan que si le han recetado insulina y la deben de tomar, se sienten como que han fallado en su propio manejo de diabetes, y este no es el caso. La insulina es una de las varias herramientas para ayudarlo a mantener el azúcar en los niveles apropiados para mantenerse saludables. Es preferido, como hablamos antemano, en diabetes gestacional, y en diabetes tipo 1 es la medicina que se usa y es necesaria. Y para diabetes tipo 2 vimos que dependiendo de su nivel de A1C puede ser recetado como la medicina principal con otras medicinas orales que lo puedan ayudar en alcanzar sus metas.
So let's talk about insulin. Sometimes people think that insulin is a punishment or that they failed. That's just not true. It's an important tool to help keep you as healthy as possible. And it's used exclusively, or it's not exclusively, but it's always used with people who have type 1 diabetes, and also generally people who have gestational, which is when you're pregnant, when a woman is pregnant. But it's also used with type 2 diabetes in order to help you meet your goals so that you stay as healthy as you can.
And also we always said on the previous slide, when we reviewed the A1C, if someone starts off with a very high A1C, you already noted that we would start insulin with other medication.
Thanks.
Tipos de insulina. Hay 6 tipos principales de insulina: rápido, regular, acción intermedia, acción prolongada y acción ultralarga y inhalada. La insulina, como había dicho antes, le dice a las células de todo el cuerpo que tomen el azúcar del torrente sanguíneo. Ayuda al cuerpo a convertir el azúcar en sangre en energía para usar de inmediato, o también almacenar el azúcar que está presente en la sangre no utilizada de una vez para energía dentro de los músculos, el hígado y las células de grasa, para luego usarlo como energía en el futuro. Los efectos secundarios más comunes, sin falta, voy a decir que es hipoglucemia, la azúcar baja. Puede causar aumento de peso, especialmente al inicio del uso, pero eso se debe de nivelar después de un tiempo. Y también problemas donde mismo se inyecta la inyección, puede haber erupciones o cicatriz si no rota el lugar donde usted se inyecta.
So there's 6 main types of insulin: rapid, regular, intermediate acting, long acting, and ultra long acting. And then there's also inhaled insulin. What insulin does is it tells the cells throughout our bodies to take in sugar from the bloodstream, and it helps us turn blood sugar into energy. That's so our blood doesn't have too much sugar in it. It helps the body store additional unused blood sugar in the muscles, liver, and fat cells, so we can use that energy later. The most common side effects are initially, at first, it's possible to have some weight gain, but usually that levels off quickly. It also can cause hypoglycemia, which is low blood sugar, and that's why we have to check our blood sugar regularly to make sure that it's not getting too low. And sometimes people have problems at an injection site, and Ruben's going to talk a little bit about safe injection techniques to make it less likely that we'll have scar tissue or rash and moving injection sites around in a couple of minutes. So here's a video that we're going to show how to use an insulin pen. This is a Lantus pen. And I think you're going to, I don't know how we're going to do it. Are we going to try it here, or you'll just come out and go back in, Ruben?
No.
I think it's probably the right time. Yeah.
You see the video?
No.
Okay.
We can't see the video because it's currently showing the
Right, you have
presentation
to
itself.
stop. So Ruben's going to stop sharing his screen for a second, and then he'll get the video ready, and then he'll share his screen again, and then he'll stop sharing, and then we'll go back to the presentation. It's a very short video, and it's a really good one that shows how to use the Lantus pen, which a lot of people have. So give us 1 second. Here we go. All right, it doesn't have sound. It's all right. So do you want to say what it's saying in Spanish, Ruben?
Yes. So we're mounting the needle now. Estamos aplicando la aguja. Estamos destapando. We're removing the two covers. Antes de usarlo para la primera vez, vamos a ver si está funcionando apropiadamente. 2 unidades de insulinas, pulsar el botón y a ver si sale la insulina de la aguja. Debe de ver las gotas de insulina salir. Si no aparece después de hacerlo 2 o 3 veces, debes de reemplazar la aguja. Y si no está funcionando, también hay que reemplazar el lápiz. Inyectando la insulina, debes de marcar la dosis apropiada. Y ya han insertado la aguja dentro del cuerpo y pulsar el botón y dejarlo por lo menos 10 segundos antes de removerlo. Hay diferentes tamaños de agujas. Deben de usar las más cortas y luego vamos a repasar cómo desechar las agujas en la pantalla siguiente. Okay. So we'll go over the disposal in the next slides.
So he's just putting the presentation back up, and then you'll see the presentation again. Just a couple more minutes, seconds. There we go. Okay.
Great. So, lugares para inyección de insulina. Puedes ver en el cuerpo los lugares para inyección. Se prefiere el abdomen, donde está el estómago, evitar el ombligo a 2 pulgadas alrededor. Los brazos posteriores, los muslos y los glúteos, parte arriba de los glúteos atrás, en el trasero. Y el objetivo es depositar la insulina en la capa grasosa, debajo de la piel, no en el músculo. ¿Cuántos segundos debes de contar después de presionar el botón? Por lo menos 10 segundos. Dicen de 7 a 10 segundos, es mejor esperar el mayor tiempo para asegurar que la dosis completa ha sido depositada. Reutilizar agujas es peligroso. Pueden ver abajo, mano izquierda, una aguja nuevecita de paquete, a mano arriba, y a mano derecha, en la parte superior, puede ver después de un solo uso. Se ve ya usada, la punta se ve mínimamente doblada, y estas agujas vienen prelubricadas de la factoría. Es importante usarlo una sola vez. A mano izquierda abajo, utilizada 2 veces y después de 6 veces al fondo. Hay pacientes que rehusan las agujas. Es importante solo usarla una sola vez.
So insulin injection sites, arms, abdomen, thighs, buttocks, like you'll see in these pictures on the right. And then how many seconds to count? So once you've found the site and injected the insulin, you should wait at least 10 seconds before you take out the needle. And that's to make sure that you're getting the complete and correct dose. Some people like to reuse needles for lots of reasons. And on the bottom left of the screen, you'll see 4 pictures. The one on the top left is a new needle, and you'll see that's very sharp and doesn't look like anything has happened to it. Right next to that, you'll see a needle to the right of it on the top. You'll see a needle that was used once, and it's got a little changes to it. A needle that was used twice is on the bottom left. On the bottom right is a needle that was used 6 times. So the needles really change. They're made to be used once. They're safer to use once. And the idea with needles to inject medication is that we use them once.
And just reinforcing what Joan was saying on the abdomen, just make sure staying away 2 inches round away from the belly button. And the whole point of the injection site is trying to make sure that we're depositing the insulin in the fatty tissue, not into muscle. ¿Tienes miedos a las agujas? Queremos repasar algunas técnicas que pueden ayudar a evaluar los niveles del azúcar cuando estás examinándose la sangre. En los dedos, con las lancetas, puede utilizar el costado, los lados del dedo en vez del centro, que tienen menos nervios y debe de doler menos. Prueba alternativa de sitio. A mano derecha arriba puede ver diferentes lugares que no son los dedos que puedes utilizar para ver su nivel de azúcar. Debe de hablar con su proveedor de salud porque solo se debe usar en tiempos en cual no se espera cambios radicales a la azúcar porque le da información tardía que ha pasado ya por lo menos hace 10 o 15 minutos. Use agujas y lancetas de calibre fino, también los más cortos posible. Levantar la piel, pinchar la piel para arriba durante la inyección. Evitar la aguja, visualizar la aguja perforando la piel. Si se siente mareado en casos de inyección, es mejor aplicarse la inyección mientras estés recostado o con por lo menos las piernas y los pies elevados, reclinados. Encuentre dispositivos con tapas cubiertas. Pueden ver al fondo a mano derecha, donde se puede aplicar antes de inyectarse. Es como un puerto de inyección que dura por lo menos 3 días y no tiene que insertar la aguja cada vez a su piel directamente. Algunas personas usan anestesia tópica, que es como una crema, y también terapia del comportamiento o de sensibilización con un terapéutico si es necesario.
So most people do fine checking the sugar by doing the finger sticks and injecting insulin or other injectables that Ruben will talk about in a couple of minutes. But there are people who are very, very afraid. And here are some techniques that might help. When you're testing the blood sugar in your fingers, there are lancets, which are the tiny needles that we buy to do that. Using them on the side of the finger can be helpful and cause less pain. So different sides, and then alternate site testing. So in the picture of the hands on sort of the top right, you'll see different places where we can test our blood sugar. Also using fine gauge needles and lancets. As we showed in the prior slide, you'll see, well, these 3 pictures of needles, and these are for injection, these show the length. So you have a short, a medium, and a long one. We want to use the shortest one that's safe. When we're injecting insulin, we want to pinch the skin up so that there's an area that's lifted up to inject into. Sometimes people do better when they don't look at the needle. They know where it is and they know where it's going, but they don't have to look at it going in. And then there are people that feel lightheaded when they get an injection. So a good idea is to do it when you're lying down or leaning back and in a safe place, especially with your legs elevated also. That can help if you feel lightheaded, and you can do it lying down. Some devices, some injection devices have covered caps. So you don't see them, and you just, for lancing, for checking your blood sugar in your finger, there's some devices that you just press a button. You're not sticking that needle into your finger. You just put it there, click, and then it makes the little area for the blood to come out. Some people use topical anesthesia, meaning it numbs the skin, and for some people that's helpful. And then if you really need more, there is therapy to kind of get rid of our fears and desensitize our fears.
And again, to just go back to the top with what Joan was saying with alternate site testing, please discuss this with your healthcare provider, because using anything other than the fingers, really that information is going to be old information, and it's not information that responds rapidly like the fingertips. You may be getting information from 10 to 15 minutes ago, and you want to be careful because you'll be dosing medication, insulin, or making decisions based on that glucose. So it's important that you discuss it with your provider. Almacenamiento, estoraje, insulina y estabilidad. Mantenga el pomo, el vial de insulina o las plumas sin abrir en el refrigerador, en la nevera, nunca en el congelador, hasta la fecha de vencimiento en la caja. Cuando ya utilizas cualquier pluma, lápiz, pomo, viales, por la primera vez, que quiere decir que tú has punzado la goma, tú has accesado la insulina, aunque sea una sola vez, puedes mantenerlo en temperatura ambiente fuera de la nevera, de 59 a 87, 86 temperatura en el cuarto, o Celsius, puede ser de 15 a 30, aproximadamente 28 días. Si no has usado completamente el lápiz o esa insulina, debes de descartarla porque no va a funcionar tan bien como debido. Las jeringas prellenadas en refrigerador, que a veces es necesario para personas que no pueden llenarlos sí mismos, pueden almacenarlo hasta 21 días nada más con la aguja hacia arriba para no tapar la aguja con la insulina, excepto la insulina de largo plazo, glargina o detemir, que es Lantus o Levemir, porque se nubla, la consistencia cambia a través de 3 días. So esa no se debe de rellenar.
So how do we store insulin, and how do we make sure it's working right, make sure it's stable? Well, any unopened pens or vials should be in the refrigerator until the expiration date that you see on the box. But once we've opened the pens or the vials, we click the top of the vial, or the pen is open and we're using it, it can stay out at room temperature between 59 and 86 degrees Fahrenheit up to 28 days. If it's out in the room for longer than that, then it has to be discarded. And then some of us pre-fill syringes, someone else pre-fills them because we are not able to draw up the insulin in the syringe. For pre-filled syringes in the refrigerator, and they should be needle up, like the picture on the bottom right, they can be stored for up to 21 days, except for glargine and detemir, which would be cloudy by day 3. So for those, Ruben, what should they do with those?
Oh, so it's not a medication you can pre-fill.
Oh, you can't pre-fill it, right?
You just have to, and because it's long-acting, you can possibly just have someone else inject it all together.
Got it. Okay, thanks.
Okay,
Disposal of syringes. So what do we do with all these sharps? We have to get rid of them, and there are a few things to do. So one thing is on the right, there's this safe clip. So it's a device that you put the needle into, as it looks like on the box, and it cuts off the end of the needle. But then you still have to get rid of those needles that you clipped off. And in that case, you can use one of the 2 items in the middle and on the right, a sharps container that you can get from any pharmacy, or in New York State, it is legal, it is allowed to use something like a laundry detergent bottle like Tide or All, something like that. And you put sharps in, never recap in any case, never put the needle back on, because it's very easy to get stuck. I've gotten stuck that way with patients before. So it either goes into the sharps container with the needle uncovered or into this, this laundry detergent bottle, and it's marked well, says sharps, do not recycle, and then that goes into the regular trash.
Going back on what we do prefer that you find a local hospital, pharmacy. At the end, there's going to be resources where instead of, you know, if you really feel uncomfortable, and I prefer to have the syringes, even if it's a detergent bottle, to take them somewhere where they will accept them. But Joan just wanted to let you know that that is legal and an option if you are not able to get to it. But we prefer you take it somewhere where they accept sharps. And I'll say it in Spanish. So eliminación de las jeringas. Oh, and going back, sorry. So just make sure you don't place it in tough food containers like a milk gallon. Just try to avoid putting it in containers that would contain food at all, especially because it could lead to problems with children getting into it or that type of thing. So I just want you to be very careful with your syringe disposal.
Good point. Yes, very important.
Eliminación de jeringas. Ahí a mano izquierda en su pantalla puede ver que tienen diferentes cosas que puede usar para cortar la aguja de la jeringa. También en el medio hay un contenedor que puede obtener en la farmacia para disponer o desechar las jeringas. Y a mano derecha, en un pote de detergente, puede marcar que tiene jeringas y depositarlas sin volver a tapar la jeringa directamente dentro del pomo y taparlo. Y en Nueva York se permite desecharlo bien tapado, sellado en la basura regular, en un contenedor que sea fuerte. Pero preferimos que usted encuentre un lugar como una farmacia o un hospital que los acepte para desecharlos ahí y no directamente en la basura. Por favor, no utilice algún bote fuerte de plástico que había contenido comida antes para no tener problemas, especialmente con niños que pueden tener acceso y destaparlo y herirse. Esta medicina GLP-1 es inyectable, pero no es insulina. La insulina no es el único medicamento que se puede inyectar para diabetes. Y esta medicina, si usted la reconoce por nombres Byetta, Victoza, Ozempic, usted seguramente ha visto los comerciales. Es una hormona que ya cargamos en el cuerpo, en el intestino, que se libera cuando comemos. Esta medicina hace lo mismo, asumiendo que hay una deficiencia en el cuerpo de una persona con diabetes de esta hormona. Estimula el cuerpo, el páncreas, para liberar insulina solo después de haber comido y para mantener los niveles de azúcar, y disminuye el movimiento, el tránsito de los alimentos desde el estómago al intestino delgado. Puede sentirse lleno más rápido durante más largo plazo y puede ser que coma menos por esa acción del medicamento. Ayuda a reducir el azúcar y el peso, el azúcar en la sangre y el peso. Suprime el apetito y reduce el riesgo de enfermedad cardíaca. Efectos secundarios más comunes, como se puede imaginar, puede ser náusea, vómitos, diarrea o estreñimiento. Efectos graves secundarios puede ser pancreatitis o cáncer de tiroides, que no se ha visto en personas, pero sí se ha visto en los laboratorios usando altas dosis de esta medicina. Y si has tenido algunos de estos inconvenientes antes, seguramente es algo que no le van a recetar.
So insulin is not the only medicine we inject for diabetes, and we're going to talk about GLP-1s first. So some of these are names you might have heard of, or people you know or yourselves might be taking: Byetta, Victoza, Ozempic. Some of these are advertised on TV also. So what do? It's a hormone. It's a normal hormone that's in our intestines that is released when we eat. So the medication copies that action. So it's a similar hormone in our body. Excuse me. It stimulates the body, specifically the pancreas, to release insulin only after you eat and the blood sugar levels start to rise. So it acts like that hormone in our body. And it slows the movement of food from the stomach to the small intestine. Maybe you'll feel full faster for a longer time and you may eat less. So it also has that impact. It helps to lower blood sugar and sometimes also lowers weight, decreases our weight because of the appetite suppression action of it. And it also lowers risk of heart disease. And earlier we talked about that people with diabetes have a higher risk of heart disease when the sugar is higher. The most common side effects are nausea and vomiting, diarrhea, or constipation. So gastrointestinal side effects. Serious side effects could be pancreatitis or thyroid cancer. If you had a history of thyroid cancer, this would not be prescribed for you.
And doesn't having the conversation with your provider about this, because it's a specific type of thyroid cancer and it hasn't been seen in human subjects as of yet, but has been seen during testing. Hay un GLP-1 oral que no es inyección, es nuevo, se llama Reversus. Tiene la misma función, pero no dicen que la inyección tiene mejores resultados. Es oral, es tomada en la mañana con el estómago vacío, en ayuna, con 4 onzas de agua nada más. No puede ser más de 4 onzas de agua. Debe de esperar 30 minutos antes de la comida o cualquier otro medicamento antes de tomar, después de haber tomado la pastilla. Y si toma, por ejemplo, levotiroxina, el Centroid para la tiroides, a veces esa medicina la mueven hacia administrar en la noche por causa de tomar esta medicina. Efectos secundarios, igual que el GLP-1 inyectable.
So just like the injectable GLP-1 that we just talked about, there's also an oral medication, meaning a pill that you take by mouth. So it does the same thing, and it's called Rybelsus. It does the same thing that we just talked about the injectable. And generally, it's given in the morning on an empty stomach with just 4 ounces, half a cup of water, and you have to wait 30 minutes before you have any other food. The side effects are similar to the injectable medication that we talked about. And Ruben, you said something about taking it in the evening sometimes. Can you repeat that in English?
Sure. So also with this medication, it is a GLP-1 also, but so far in studies, we have seen that the injectable works to a higher degree. And also, if you're taking something like Centroid, levothyroxine for your thyroid, if you're hypothyroid, sometimes they'll move that medication to the night simply because there's so many challenges with how this medication should be taken.
Thanks.
You're welcome. So we're nearing the end. Estamos llegando al final. Solo quería repasar pero por encima, todas las medicinas individualmente orales. Estas son las inyectables, ya la hemos repasado, solo no hemos hablado sobre amilin. Amilin es una medicina similar a la GLP-1 que disminuye el tránsito de comida en el estómago, pero no tiene el efecto adicional que tiene GLP-1, que es soltar insulina del páncreas cuando has comido y los niveles de azúcar están aumentando. Y es la única otra medicina aprobada por la FDA para diabetes tipo 1 que son personas con diabetes tipo 1 que tienen, por ejemplo, alto peso, que pesan y quieren que bajen de peso, y también para controlar el subir del azúcar después de comer. Jones, you mind if I say that again in English?
I was going to ask you to, right?
Okay.
Yeah,
So,
perfect. Thank you.
So again, we already discussed the GLP-1s. I just wanted to include amylin, which is another injectable product. This is normally, it's older. It does the same thing as GLP-1. It slows the transit of food from the stomach to the small intestine, but it does not have the additional benefit of releasing insulin when blood glucose rises at mealtime. And this is the only other medication FDA approved for type 1 diabetes at this time. It's normally used in type 1 diabetes when weight loss is desired, or also to control postprandial after meal spikes in blood sugar. So these are the oral medications for diabetes. Just to go over, like we said in the very beginning when we looked at all of those different organs.
Can I just jump in 1 second? I'm so sorry. If people, this is a lot of information that Ruben's about to go through in English and Spanish, and this is a handout. So later on, you're going to get Kenny's information, and if you want a copy of this handout, he can get it to you. So this is, so anything you're seeing, you can get the whole 2-page handout. Sorry, Ruben, I just wanted to make sure people didn't feel overwhelmed and writing everything down.
And this is also available for free online, basically. So just going over oral medications, the biguanides, there's only metformin in this group. It lowers the amount of glucose produced by the liver. Sulfonylureas and meglitinides, they pretty much do the same thing. They help the beta cells, which are the cells that secrete insulin in the pancreas, to release more insulin. So that's why it's so important to work with your provider, because if you're already on insulin and you're adding this medication, it usually causes even more weight gain. And it's just not the best thing to do, to be giving 2 medications that are basically working in the same area. And that's glimepiride, glipizide. TZDs, these medications help insulin work better. This is Actos. It helps insulin work better in muscle and fat cells. It really sensitizes the body to insulin, and it lowers glucose production in the liver. And out of all of the medications, this one is the most useful to have an effect on adipose tissue. Alpha glucosidase inhibitors, these are acarbose and miglatol. All this does is it blocks the enzyme that breaks down starches in the intestines. So as you can imagine, it just causes a lot of gas and bloating. Estas medicinas orales para diabetes, biguanides, metformina es la única en esta familia y disminuye la cantidad de glucosa, de azúcar producida por el hígado. La medicina sulfonylureas y meglitinides, estas 2 medicinas que son amaril, glucotrol, glimepirida, simplemente ayuda las células betas a soltar insulina, que son las células que normalmente sueltan la insulina en el cuerpo. Y por eso es tan importante hablar con su proveedor de salud, porque si ya estás inyectando insulina y tomas esta pastilla, se está funcionando prácticamente en el mismo sistema y aumenta más de peso, y es mejor usar diferentes sistemas del cuerpo para cuando están recetando medicina. TZD, esta familia que normalmente se toma Actos, ayuda a insulina a funcionar mejor, sensibilidad en los tejidos para utilizar insulina mejor en los músculos, el almacenaje que habíamos hablado antes, y en las células de grasa baja la producción también de azúcar en el hígado, y esta medicina se usa particularmente para cosas que tienen que ver con grasa en el cuerpo, en el depósito de grasa. Alpha glucosidase inhibitors, inhibidores alfa glucosidase, que son acarbose, miglitor, simplemente bloquean el enzima que en el cuerpo descompone el decompuesto de los almidones en los intestinos y causa mucho gas. Secondly, this is the second page and the last page of oral medications. DPP-4 inhibitors, it slows the inactivation of GLP-1, the natural hormone we have in the body, again, leading to GLP-1 being kept around longer and having those effects that you would expect from those GLP-1 injections and the oral GLP-1, but it doesn't work to the same degree. It's a very subtle medications, and I hardly have any side effects with that medication in patients, and that's alogliptin. You know them by Tradjenta and Januvia, basically. Bile acid sequestrants. This is really a medication for cholesterol, but it's sometimes used in diabetes. It helps lower LDL cholesterol and blood glucose levels. Dopamine 2 agonist, this is called Cyclacet. This medication works in the brain. It helps with metabolism. We rarely prescribe this medication either. It originally was a Parkinson's drug, and in a form it still is, but in a different format. It helps lower blood glucose levels after meals. And finally, the SGLT2 inhibitors, the new ones that you know by Invokana, Farxiga, Jardiance, they block glucose, sugar, from being reabsorbed by the kidneys, and you urinate the excess glucose, and it helps with weight loss and cardiac outcomes also. La última hoja que vemos aquí de medicinas orales, DPP4 es esta medicina también disminuye la inactivación de GLP-1 que ya tenemos intestinalmente, y como pueden imaginarse, tiene la misma utilidad que las inyecciones GLP-1 o la oral GLP-1, pero no con tanto efecto. Y lo recetamos, pero no tiene gran impacto en la azúcar. Eso es cuando necesitamos disminuir los niveles de glucosa. Y los secuestrantes de ácido, podemos ver, se llama Welchol, colestevelam. Es una medicina normalmente para colesterol, pero también ayuda a bajar la azúcar. Agonista de dopamina que se llama Cyclacet o bromocriptina, se usaba primordialmente para Parkinson, todavía se utiliza en una forma distinta, también ayuda a bajar el azúcar después de las comidas y funciona en el sistema nervioso, en el cerebro. SGLT2, usted lo conoce por Invokana, Farxiga, Jardiance, que hay muchos comerciales ahora, bloquea la glucosa que no debe de ser reabsorbido por los riñones, y se orina la glucosa. Se ve bajo en peso, y también efectos positivos cardíacos con esta pastilla. Diabetes con un presupuesto. Estamos ya llegando al final. Si le recetan unas medicinas y ve que es muy caro o cara, debe de ser cambiada a una que es de acuerdo a su plan de seguro, pero a veces hay personas que no tienen seguro. Yo recomiendo que en la red puedan ver goodrx.com y pueden buscar descuentos, cupones, programas de descuento directo con la compañía de farmacéuticas de acuerdo a la medicina que quieres utilizar, y probar suministros. Farmacias como Walmart y Costco tienen descuento en no solo probarse el azúcar en esas máquinas, pero también las medicinas. Servicios de medicamentos en la red y entrega a domicilio, y las medicinas que han sido utilizadas por largo tiempo, que ahora se pueden comprar a muy bajo precio, que incluye la metformina con las medicinas orales, sulfonilureas, como habíamos hablado antes, migletinides y los TZDs. Las insulinas más baratas son NPH, que es lenta, la insulina regular, que es un poco más rápida, y la 70-30, que es insulina mixta, con lenta y rápida a la misma vez.
So diabetes on a budget. There are a lot of medications and not everybody has health insurance. And even those of us who have health insurance, maybe it doesn't cover some of the medications we need or leaves us with a big copay. Some places to check are goodrx.com to see if the prices are lower. And also some pharmacy companies have direct discount programs. So maybe you can reach out directly to the pharmacies. The testing supplies, the glucometer, the machine that you check your blood sugar, the machines are very inexpensive. What's expensive? What is expensive are the little strips that we put in. Check with your pharmacy to see what's the least expensive and how you can afford them. There are some online home delivery services that are less expensive, and it's worth looking into all of them. PillPack, Capsule.com, CVS Caremark, Optimum RX, Express Scripts, but also speak to your neighborhood pharmacy. Maybe they want to keep your business and they might have ways to lower the cost. The kind of medications that may be less expensive or that may be covered by some of these programs are metformin, you can just read them because I'm not good at saying all of them. And then the MPH insulin is less, the three insulins that are less expensive are MPH, which is long lasting, regular insulin, which is more fast acting, and 70-30 insulin, which is a mix. The insulins which tend to be more expensive are the pens and some other insulins.
Yes, and these medications have been around a long time. And that's why they tend to be the least expensive. And they may not be optimal, but they really do work. Questions, preguntas? Joan, you want to take over this section?
Sure. Kenny put in the chat, so those of you who are looking at the chat, there's a link to the handout that listed all the medications that Ruben just went through, the yellow and white handout. So you can see that by clicking on that chat.
On the chat, I also put in the YouTube video that you showed earlier. We do have a couple of questions today. Let me go over a couple of these questions. Just a second, please.
And while you're doing them, maybe you could put up, here are all the resources. So there's quite a few here that Ruben developed. So thank you, Ruben. You could put up the survey also if you want, or we could wait till after the questions.
Right.
So there's a survey.
I'll do both at the same time. So the first question is, what are the common side effects of insulin?
So the most common side effect is low blood sugar. The second one that people complain about, especially in the beginning, is the weight gain that's associated with insulin, especially in the beginning when someone starts using it. But there are a variety of reasons why. And one of the reasons could be the fact that if someone had high blood sugar for a very long time and they've been losing weight because they've been basically burning off fat inappropriately or basically urinating a lot of sugar, dehydrating, once you see all of that weight loss, which is one of the consequences of being hyperglycemic all of the time, once you start insulin, you start to gain some of your normal weight back, and some people gain more than their normal weight back. And we try to balance that out by the carbohydrates that someone is consuming while they're on insulin.
We'll do it in Spanish. ¿Cuáles son los efectos secundarios de la insulina?
So el efecto principal de la insulina es azúcar baja. Y segundamente, los pacientes se quejan de aumento de peso, pero puede ser que en tener azúcar alta por largo tiempo, un efecto resultado de eso es bajo de peso, no es un bajo de peso saludable. Tiene que ver con quemando grasa inapropiadamente y también orinando bastante azúcar y perdiendo volumen a través de deshidratación. Pero normalmente es al principio de usar insulina que se ve el más aumento de peso y debe de nivelarse, y otra manera que podemos evitar el aumento de peso es controlar los almidones, los carbohidratos que se ingieren y en sí afectar la cantidad de insulina necesaria para normalizar el azúcar de acuerdo a lo que se está comiendo.
And then the next question is there any current medication to cure diabetes or any research-based medication conducted to cure diabetes?
Yeah, so I like that question. We get that question a lot. I think we addressed it in the first or second course, but not everyone got to see it. So we look at the remission. We don't call it a cure. I believe a cure is more along the lines of when someone gets gets a pancreatic transplant, let's say, which means the person goes now on permanent anti-rejection medications so that that transplant doesn't fail, but they remain insulin-free for the most part or medication-free for diabetes. But the remission of diabetes is being at an A1C of less than 5.7 for a whole year without diabetes medications. That's considered the textbook definition of remission of diabetes. And there is no medication to basically reverse diabetes, but the whole diet, nutrition, exercise piece in combination with medications, if necessary, can help you get to the target of the remission of diabetes. If someone has type 1 diabetes, remember it's a lifelong insulin administration, but the possibility for that person would be a less insulin dose rather than larger doses. That's really the target for someone that has type 1 diabetes. So la pregunta era si hay una medicina para curar diabetes. Normalmente para curar diabetes se ve trasplante del páncreas en el cual la persona debe de tomar medicamentos para oprimir que el cuerpo no deseche el trasplante. Y esas personas no utilizan insulina o medicinas orales para diabetes. Segundamente, la definición de cura de diabetes es mejor dicho, remisión de diabetes es cuando no se usa medicina por un año y el A1C se mantiene en menos de 5.7% durante ese año completo en no tomar medicinas para diabetes. Como estaba hablando antes, la dieta, la nutrición y el ejercicio y medicina si necesario es lo que se utiliza para alcanzar esa meta, para llegar a remisión de diabetes. Una persona con tipo 1 que depende de insulina, puede ser que disminuya la cantidad de insulina que debe de tomar a diario, pero no removerla completamente. Esa no es la meta para diabetes tipo 1.
I just wanted to remind people who haven't filled out the survey, about half of you have. So if any more of you would like to do so, we'd appreciate it. I'm sorry, Kenny, I know you have another question.
And the first question, I actually have one more question here. And I got this earlier on, but we'll still answer it. Can insulin be administered orally?
So we have inhaled insulin. That's not an injection. But that insulin is only rapid acting. So someone who has type 1 diabetes, we wouldn't use that because remember for type 1 diabetes, we're trying to mimic what the pancreas normally does. So you need a long acting and a short acting insulin. So right now it's really for type 2 diabetes. I'm not saying it's not being used in type 1 diabetes by some providers, but that basal insulin component is so important. Oral insulin, there are a lot of studies on that for other uses, but oral insulin, that's something that's in research. That's not something that's really, it's not something that you can prescribe or take at this time. You may be able to enroll in studies for that. But the problem with insulin is that it's a protein. If you were to, for example, swallow the insulin that we prescribe, the acid in the stomach and everything, it would just decompose the insulin and it just wouldn't work. It wouldn't do what what it's supposed to do. So right now, oral insulin is not on the table. La pregunta era si hay insulina oral. Si hay insulina que se puede inhalar, pero es reservado para personas con diabetes tipo 2 porque es insulina rápida nada más. En diabetes tipo 1 se requiere la insulina basal, la insulina lenta, y no estoy diciendo que no se está usando la insulina en combinación con la insulina basal con esa inhalada en tipo 1, pero no es algo que es recomendado. Y hay pastillas de insulinas que están en proceso de examinar, pero son para otras cosas. No es algo que se usa para diabetes. Si quiere enrolarse, al final pueden ver aquí en tipo 1, Diabetes Trials, puede ser que encuentre un programa que puede enrolarse para algo de ese tipo, pero en este momento no. Si usted se traga la insulina que utilizamos ahora, solo se va a descomponer en el estómago y no va a funcionar, no va a tener la función debida.
I do not have any more questions at the moment.
Okay. If anything, you have our contact information when you review the slides. So you'll be able to reach out to us via email if you have any questions or concerns or any additional questions.
Right. I also sent out our YouTube channel. So this recording will be uploaded within the next 24 hours. So be on the lookout.
Thank you so much, all of you for coming and for filling out our survey and for being concerned about diabetes. And we look forward to seeing you again soon. Thank you so much.
Thank you.
Muchas gracias por atender el día de hoy. Tengan un buen día. Thank you. Thank you, Joan. Thank you, Ruben.
Thank you.
Thank you.
Bye-bye.
Thanks, Kenny. Thanks, NYP and everybody.